Mewison had a emergency back at his institution, so he could not make it. So really want to thank Dr. Sir for stepping up and taking this talk. I would like to introduce Dr. James Sir. Why should I stay intraluminal during below-the-knee occlusions?
Thanks, Jaafer. So being the pinch hitter, we'll get started and see what we can do here. I always enjoy days like this because your themes of the way you think and the way you progress through cases continue to come up, and it's a little validating. Those are my disclosures. So coming to this topic of staying true lumen below the knee, this is really an opinion piece from my practice and a little anecdotal, because what I looked, there just isn't a ton of data that tells us what to do and the benefit. But what is out there, you're looking at this registry data, 40% of critical limb ischemia have CTO. And in this small patient subset, looking at those that were crossed with the Viance or the crossbus system, you can be successful at a greater than 65-70% rate. Lesion length is the largest predictor of being successful. If it's less than 15 centimeters, you'll fail about 25% of the time. If it's over 15, you'll fail close to 50% of the time. In lesions less than 10 centimeters, the Viance at least showed 88% success rate in staying true lumen. CTOs offer longer procedure time, radiation, and contrast. The concept of benefit, staying true lumen over the subintimal course below the knee, from my perspective, is number one, to preserve collateral flow, keep open more options of intervention. You don't have the challenge of reentry and its complications. You reduce the use of stents below the knee, which still carry controversial results and cost. And for critical limb ischemia, oftentimes we're trying to achieve wound healing, which doesn't often necessitate a long-term durable result. So looking at collateral flow, if you've ever driven down the Kennedy going north, there's an exit about every 500 feet. And this is what I think of when I think of collateralization. If there's a big traffic jam on the way to Wrigley, you can get off and you can find your way there. If those roads are closed, you get gridlock. And so preserving collaterals, I think, is an extremely important part of below-the-knee intervention, and for that, staying true lumen has value. You look at large collaterals that come off right at the entry and exit sites of our lesions that we're trying to treat. And a lot of times coming down and making attempts at CTO crossing, we can get subintimal and we can jeopardize these important collaterals. So the impact, data that is out there supports that up to 47% collaterals distally and 26% proximally are lost after we angioplasty a subintimal plane. Abrupt closure of a vessel then subsequently leads to acute limb ischemia from someone who's at critical limb ischemia. Collateral flow may continue to feed, enforcing subintimal tracts, which can then ultimately close in a subacute fashion unless we preserve those with stenting. And the use of stents is often needed at entry and exit of subintimal planes, often closing more important collaterals right at those important cap sites. Keep open more options for intervention. Staying true lumen, I think, offers us a full armamentarium of treatment. We can use Diamondback, Phoenix, Silverhawk, any atherectomy system that you choose. Whereas I think if we're in a subintimal plane, sometimes we limit ourselves. Laser, PTA, stenting, all those things are on the table when we're trying to treat critical limb ischemia. You don't have the challenge of reentry and its complications. So looking at that, eventually we have to reenter the true lumen. That attempt often extends the lesion length, which again, the length of these lesions is a major predictor of restenosis. Complications that can occur in the subintimal space and at the reentry site are perforation, hematoma, and bleeding, which occurs up to 15% of the time. And these rates are higher at that reentry site. Use of additional equipment to reenter, IVUS, reentry balloons, wires, catheters, all that cost comes into play. And the vessel injury may accelerate vessel healing response, which ultimately leads to restenosis. Again, need to secure that entry and exit site with stents in a subintimal plane, again, adds cost and metal. So reducing the use of stents, BTK, which still carries controversial results and costs. If we stay true lumen, we won't often have to utilize this. And although the data is better with DES over BMS and DES versus paclitaxel-coated balloons, restenosis rates still remain high. Committing a patient to a stent below the knee has limited long-term benefits, but often is required to keep that subintimal tract open and patent. Often several stents are required to keep the vessel open, which adds costs, and is generally not reimbursed well, if at all. And the longer the lesion length treated with stents, the worse the patency rate long-term. And CLI, really in this treatment of CLI, oftentimes we are trying to achieve wound healing, and again, the durable result isn't always absolute. However, looking at reocclusion rates, patency rates really are needed for the duration of the wound, and the wound can take months to heal. PTA alone can offer a durable patency rate for that intention. Data from CSI and patency with CLI remains better when staying true lumen. And in the coronary subdata, or the data from CTO, crossing CTOs, certainly if a true lumen course over dissection reentry course is endorsed, reocclusion rate is lower. So, taking a case I did recently, seeing the collateralization here, staying true lumen, actually you don't see the collaterals after you fix this because you have such great inline flow, but they may lay dormant and still are able to be utilized if you have occlusion down the road. This is a vessel that I crossed, and I actually used angiojet because it was fairly recent occlusion, superimposed on some tight lesion. We found a few tight lesions, did atherectomy, and then drug-eluting balloon, and had a nice result. And this is the patient's toes. Still crusty and gross in the right image, however, that's immediately after the toe removal, and now I know from podiatry that the patient is completely healed. So just to summarize it, the concept of benefit staying true lumen, again, for me is preserving collaterals, keeping more options open for my intervention at that time. I don't have the challenge of reentry and the complications that come with it. I reduce the use of stents, and again, I'm trying to achieve a wound healing result, not always a necessarily patency at 2-year result. Thank you.
Thank you, Jim. So I'm going to talk about image-guided atherectomy, early results of the VISION trial. So this is a very exciting trial because it's a brand new technology, nothing like this that we've seen before in the US, and we've been waiting for this type of technology for quite some time, and finally we've had access to this as part of a clinical trial. It's the Pantheris atherectomy device, which actually comes from the mind of Avenger, the same people that brought you guys Ocelot. So this is how the device works. It's basically, think of a directional atherectomy device, a TurboHawk, with OCT imaging capability. It's a little bit different in that it does not have the jog that the directional atherectomy TurboHawk has. It has a balloon on the opposite end, which you can inflate and deflate and improve both, oh, there it goes, there's a balloon right there. You can improve both imaging with that as well as pushing the atherectomy device against the plaque in order to perform atherectomy. So as you can see, the laser that gives you the OCT imaging is mounted on the directional atherectomy catheter on the blade itself. So as it rotates, you see live imaging as you perform atherectomy. So that's a cartoon depiction of that, and this is actually a real case. This is what it looks like, and this is pretty incredible. We've never had such quality images because this is OCT, and this is an unparalleled type of technology. It gives you safety, and that's hopefully what we're going to demonstrate in the VISION study. Safety because now you can actually see what you're cutting and stay clear of the media. There we go. There we're stopping right at the media, and remove plaque alone. There on the left-hand side around 9 o'clock, you see thrombus. That's pretty interesting. See thrombus, you inflate the balloon, compress the thrombus, and remove plaque and thrombus in one cut. Very interesting technology. So the Pantheris OCT-guided technology, here you see some examples, still frames of what you're looking at. And again, big steep learning curve there, just like the Ocelot device. You have to know what you're looking at, because if you don't know what you're looking at, you don't know what you're really cutting. So you have to be aware of the media, the external elastic lamina. You see the troughs here are actually much bigger than what we see with the directional atherectomy device. You have much larger, deeper troughs than you do with the other devices, so a little bit more inefficient. However, you cut at a less speed than the traditional TurboHawk atherectomy device, because the imaging device is mounted on the cutter itself. So this is an example of one of my cases. We enrolled 12 of the 140 patients, I believe, around there. And this is one of our cases that we have, is a chronic total occlusion. You can see on the left there's a pre-image and post-atherectomy. You see a significant improvement, and then on the right, post-angioplasty. And here's a tissue that was removed from that. And the interesting thing is we sent all of these cases, the tissue, off for examination, and we looked at the intimal plaque, the medial tissue, and adventitial tissue. The deeper you go, the worse the outcomes. And so here you see no adventitial tissue. There were 20 sites from across the country. The inclusion criteria: de novo lesions greater than 70%, less than 15 centimeters, with at least one patent tibial vessel. Exclusion criteria: major calcium, a proximal lesion, instant restenosis, acute limb ischemia. The traditional exclusion criteria that you would think of. So we had 130 patients enrolled, representing 164 lesions. 128 of those patients were available for follow-up. 2 dropped out. So and remember, this is a proof of concept for the FDA IDE trial. So this is safety and efficacy endpoints. So the primary efficacy endpoint was less than 50% residual stenosis post-Pantheris, and the secondary endpoint was less than 30% stenosis post-Pantheris, and then some type of adjunctive therapy. And we'll get to the results in just a second, so they obviously exceeded this. It's very interesting. And the safety outcome was perforation, dissection, embolus, pseudoaneurysm, or any other MACE, such as cardiovascular death. So here are the efficacy endpoints. So post-Pantheris, less than 50% stenosis, passed. They were supposed to meet 86%, 75% to pass it. They were at 96% primary efficacy. Secondary efficacy of less than 30% with some adjunctive therapy was also exceeded, and it did meet both primary and secondary efficacy endpoints. So here are the comorbid demographics. Obviously, a pretty high-risk subset of patients, including diabetics at 43%. The lesion length, the lesions were mostly superficial femoral artery. Task A were 77%, and Task C were 2.5%. Task B was 19.8%. Severe calcification was excluded. 23% had no calcium, 75% had mild calcium. And I will say that calcium is one limitation of this device. And remember, this is a first-generation device that we're dealing with. And all of these were de novo lesions. And when you look at the total cohort, the standalone atherectomy lesions treated, 55% were standalone. With adjunct balloon angioplasty, 40%, and only 4% actually had a stent implanted. So we really tried to stick with using atherectomy alone. And we have that ocular reflex of, let's go ahead and balloon it, tack it up a little bit. That's why we went with balloon angioplasty and 40%. And as what we saw is the more comfortable we became with the device, the less likely we were using angioplasty and stenting as well. So obviously it was a comfort level that we saw. And again, this is going to improve with the next clinical trial. When you look at the CTO subgroup, so 20% of these patients had chronic total occlusions, and 41% of them were complex and long lesions greater than 10 centimeters. And in that subset, only 3% were actually stented. So most of these were was atherectomy with angioplasty. And we had improvement of ankle brachial index as well as Rutherford classification. Now let's look at the safety events. So the 30-day overall MACE, there was a 3% overall MACE rate due to cardiovascular death, and these were not procedure related. They were within the first month. I think one person had a myocardial infarction, somebody died of lung cancer, and there was another death, but they were not related to the procedure. In terms of device-related events, there was one event which was a dissection and 3 distal embolizations. My thought process is always to use a filter. So I used filter in all of ours. One of the emboli was no filter use. One was actually after angioplasty, and one was during the filter removal process that had an embolic event. However, they were all aspirated and no clinical sequelae after this, after the embolic events. So when we look at the tissue characteristics, when we sent all these tissues back, what we saw was that 1% of the entire cohort had adventitia. There was 61% had 0 adventitia, and 94% had less than 5 adventitia. This is very, very interesting because you're able to actually visualize and stop the atherectomy device when you get right into the adventitial plane or medial plane, and that will hopefully translate to decrease TLR and improve primary patency. And this did not change even if we treated longer lesions. And no matter how much we treated and how deep we went, we were able to stop without disturbing the adventitia in most of these cases. So in conclusion, with the VISION trial, again, this is first generation. This is a proof of concept trial. This is a 30-day results. Now this is going to go out to 6 months, and that's going to be released later this fall. However, the 30-day results were positive. They did meet their primary efficacy endpoint. 55% of these patients had standalone atherectomy. There was only a 4% stent rate in the primary cohort, improvement of ABI, Rutherford classification, and we're going to be looking, as I mentioned, with 6-month safety and efficacy outcomes. And it's a really exciting time for this technology. Thank you. How are we doing with the live case? Are we ready for the live case? Okay, great. It sounds like we're ready for the live case. So we're going to go ahead and go back to Dr. Matarjame for his live case at Good Samaritan Hospital.
That was a cat there. This one is going a lot better. No problem.
Good afternoon, Amir. It's Jaafer Golzar. I'm here.
Oh, hi, Jaafer.
Hello, I'm here, and on the panel today we have Dr. Lou Lopez, Dr. Srini Iyengar, your best buddy Craig Walker's here, Mike Miller, and Jim Sir. So we're live. We got a good image. Why don't you tell us a little bit about what's going on with this patient?
Yeah. Can you turn the volume up a little bit? Yeah. Well, you saw the angio today, superficial femoral artery. The main problem and the lesion that was really bad is right here in the adductor canal, which I'm going to inject one, and we'll look at it together. So what I did off camera, I crossed that, crossed the lesion, was a little bit, I tried really hard not to dissect any of that tiny lumen. And then I'm planning to do atherectomy, so I put a distal protection. There are 2 or 3 different type of the hydrophilic catheters that we use. One of them is quick cross, and one is the one we over here we use here is a catheter by Cook, and that has a smaller, tinier tip. But unfortunately, it seems the inner lumen of it is not as big as quick cross. So we had that catheter in first, but we couldn't pass the distal protection. So we have to change the catheter with quick cross. But anyhow, we put the quick cross down there, and now we're going to do an IVUS and take a look at that lesion in superficial femoral artery.
Amir, what was the patient's presentation? Was it a claudicant or a critical limb ischemia?
No, it's mainly claudication. He had claudication of the right buttocks and left calf. And here we are right at the tight lesion of superficial femoral artery. As you see, there is a calcification all around that. Mm-hmm. And here we're going to go through the lesion.
Amir, we can't see the IVUS. Can your team put the AV team put the IVUS on? There we go.
Amir?
Okay, now you can see it. I'll go back a little bit. And you see here is almost, okay, now you see the calcification. Here is almost total occlusion. And now you picking up some lumen again. See where we are on the floor. Okay, we passed that. What I like to do here to measure this artery at that point, let's measure that, please, wall to wall. Because we want to know what size balloon we're going to use. That's 5.5 by No, I don't think we're measuring right. I don't think this is wall to wall. I think you're measuring the calcification. Yeah, that's what we want. From that point down to, go down to that's the real size. Okay, so it's about like a maximum is 6 millimeter balloon, and we probably can put a 5 in and dilate that vigorously, see if that would be enough or not. But anyhow, we are going to take the IVUS out. And now, Jaafer, would you, ask our friends on the panel to see how they would treat a lesion like this? There's so many things you can do today.
No, that's a really good point. And what did you use to cross that? It seemed like a pretty straightforward lesion.
I always use glide wires.
All right.
And it's you can use, of course, 014, 018 wire. But once it's heavily calcified like that, that wire is a little bit clumsy and just fold over. And so I used a glide wire, and I really had to work with it a little bit very carefully to be able to navigate it through the tiny lumen in the proximal. Then it was going medially, then there was another bad lumen and going laterally, and that's what I use. You know, you can always, I've seen some people use angle catheter at that point, but my wire, probably 90% of the time I use glide wire, and I can navigate that pretty good. So we went through that. Then I put cross catheter by Cook, because that goes through the tight stenosis a lot better. But unfortunately, we couldn't put the distal protection. It was a 6 millimeter. If it was 5, probably would have gone through it. But it was 6 millimeter. It was a little bit bulkier, and that didn't go. Then we have to go and change the catheter into quick cross, and then we were able to pass that in. And that's where we are now. Now, getting back to my question, and what would you do next from this point on?
Amir, this is Shruni Iyengar on the panel. Quick question. What does the runoff look like in, below the popliteal?
Runoff is good. Runoff is 3 vessel, Jaafer. We looked at it this morning. He has a pretty good runoff. There's no problem down there.
So, Amir, this is Lou Lopez. I would probably use one of the rotational atherectomy devices because of the heavy calcium. And you have a filter in, so you're relatively protected against distal emboli. And
let's go with that.
I'd see how it looks after that.
Okay, you're in practically the same wavelength that we are, and we planned that to do Fox Hollow atherectomy, and we already have a 7 French sheath in. It's good size for, the right size for atherectomy, and we're going to just limit our atherectomy to.
Amir, are you concerned the nose cone isn't going to make it through this lesion with the calcium there?
What was it? I'm sorry. I have
do you
a
have-
little bit problem hearing here.
Sorry about that. Just, do you have concern your atherectomy system is not going to make it through that tight lesion with the calcium there? And conceptually, starting with a rotational system to make a pilot hole would be something to consider.
Yeah. You're absolutely right. And as a matter of fact, I'm experiencing that right now, tightness here. And what I do usually, I push my atherectomy catheter through that first, make sure that eventually will go, and also give it a little bit pre-dilatation, and because this atherectomy is bulky enough, and then I'll try to do atherectomy. Turn it on now. Now we're going to start from here, very gently go in. Right now I have no problem going through it. At the beginning I did, and you were absolutely right about that. And okay, stop that. And we're going to rotate that to exactly the opposite side. Go ahead. And where the disease is, usually we try is, jump through it. And okay. Now I go in between. Assumedly, go ahead. Doing all 4 corners. But you never know with this atherectomy. It doesn't really have good control of. A lot of time you aim it, let's say, on the media like this, but once you turn it on, it turns by itself in a different direction.
Amir, Craig,
And that's the shortcoming with this device.
Amir, Craig Walker here. I really like your choice of tools here. I think it's interesting by having first gone with the 5 French catheter to cross and deliver your distal protection device. You, in essence, dotted through this area first to about 1.7 or so millimeters, which I think allowed you to cross this without pre-dilation. And that can be another advantage of the 035 wire. My question for you is, let's say you get a really nice atherectomy result. Are you going to stop there, or are you going to consider the use of a drug-eluting balloon adjunctively?
Well, you know very well that with atherectomy, you don't get 100% result, uniform result. Some place look better, some place doesn't. We always end up doing balloon after atherectomy, and even when it looks nice angiographically. But there's a lot of the fault that is covered by contrast. So I always balloon that after atherectomy, and then today with having drug-coated balloon, of course, you know, that's one thing that we have to use it to find out really is it as good as they claim. And so that's probably is the right thing to do now. Let's see what I should have pulled that higher up. Okay, I think my atherectomy catheter is, let's take this out because we're not going to use it anymore. I think the atherectomy catheter, I didn't pull it high enough. I'll take it out and do another injection to see the result. Then we're going to balloon that, do a pre-dilatation. Let's empty that one first. Give me some contrast. Yeah. Okay, let's see now with the atherectomy out. Now see, atherectomy was holding up the flow. Well, there is still significant narrowing there, but it's 10 times bigger than it was because it was really down to nothing. Yes, you were saying.
Amir, Jim Sir here. You know, with elongated lesion in the SFA like this, are you going to cut more above that focal lesion? Your system was, I think, corked in that lesion that's about 7 centimeters upstream from your tightest spot. So how much atherectomy do you plan to do with this vessel, or are you going to just keep it focal at that lesion?
Well, my plan was to cut that proximal stenosis as well. And because of the image was sort of poor, I didn't see that, I missed that, I didn't do it. But I think that would balloon, you know, do okay with just dilating that. And either we can do that or we can go back with the atherectomy. And this is, would you show this? We didn't get a lot of the plaques out, but this is just from the stenotic area that we, it was really a short but very bad lesion. The rest of the artery was not that severely stenotic. I'm sure if we go back and do that proximal stenosis, that will get more stuff out. And but because of the time, and I don't want Jaafer just told me that we're going to go off the air before you see balloon dilatation. So we're going to dilate that with a 5 millimeter balloon. For pre-dilatation, then we'll do a drug-eluting balloon of 6 millimeter.
Well, while you're doing that, for the benefit of some of the fellows in the room that I see in the back, it's really important. He's done so many of these. He knows already what system he's going to use, what catheters he needs to get his filter down and all that. But backing up a couple steps, you know, Dr. Walker's point was valuable that he was able to get a 5 French catheter through this lesion, therefore deliver a spider for which he can use directional atherectomy. If he found out he couldn't get through that lesion and needed orbital atherectomy, he would not be able to use the spider. He would have to use if he wanted to filter it with a NAV6, and that's a different approach and technique. So I do like that he crossed with a catheter that he knew he could get through, probably with the Silverhawk system, and then proceed from there.
Lou, you'd mentioned that you might here use a CSI device, an orbital atherectomy device. Would you use a filter with that in this dense calcium?
So the CSI device works great on this kind of a lesion. The Jetstream device works well.
Would you
I
use
like
filters?
both devices, but because the filter is easier to use with the Jetstream, I sort of tend more toward that, and I'd probably have gone with like the, I call it the jumbo jet, the largest one, the 2.4 by 3.4, and just gone through that 2 or 3 times with the blades down, and then, you know, just, I'd keep going with the blades up until there was 0 resistance, and then followed it with the drug balloon.
So, Mir, this looked like it dilated pretty easily, and all of the atherectomy devices have shown improved compliance after we remove some tissues. What sort of atmospheres did that take?
We usually, if we do only balloon dilatation, we were not planning to do drug-coated balloon. We usually leave that for 3 to 5 minutes. But right now, we're going to, this is just for pre-dilatation, then we're going to put a drug-eluting balloon in. So we're going to take it down soon and then move on with the drug-eluting balloon. Yeah. Let me just dilate a little bit down here. I don't think we have anything that bad down here.
Amir, which device was that?
And if you see, I'm still dilating the balloon by hand. And 6. Now, there are many other things we could have done here. One of them is that we could have done a atherectomy and a dilatation, and because this is a diffuse disease, we could have used a Viabon from where I end up right now dilating, and don't do any further dilatation below that, because you don't want to do a dilatation below where you put the Viabon. And we can stop right there, and then we could have put the Viabon from that point all the way up to the origin of the SFA. But the really bad portion of the this artery is just where we're really dilating, the very first dilatation. And since we want to use drug-eluting balloon, so we limited everything to that segment. And I'm sure just that segment will, fixing that, it will take care of his claudication. Now, the patency rate, I don't know. I don't know how well. I know he's going to get significantly improved, but how long it's going to stay patent, I don't know, compared to the other things. One other thing you could have done here is just put in the regular stents and stent it for a longer lesion, and that will do fine too. But as we know, there is about at least 30% rate of instant restenosis. So there are so many things when you treat a patient. There are so many things you have to consider. Well, one thing you have to remember that we don't try to treat only the disease. We try to treat the patient, and one thing might be acceptable. I can see the markers. One thing is acceptable for one patient, it might not be acceptable in another patient. So you consider the patient's age, patient's symptoms, and comorbidities, and a lot of the other things. And so you make a decision what to do at that point. And this gentleman is 91 years old, and he is very good for his age. He's well kept. He is good enough that he complains of claudication because he walk a lot. And so I think we just improve this segment and relieve his symptoms. Probably we've done the right thing. And as I said, you know, in SFA you have so many different options as far as treatment concerned. I remember the days that the only thing we had was balloon. So we used the balloon. We still used to get good result for a period of time. And if the lesion was short, and still, if it's a very short lesion, still balloon dilatation is sufficient. And it gives you very long-term patency. But the problem is with the diffuse disease in superficial femoral artery. And unfortunately, 80% of the SFA, when we get to see him, have diffuse disease.
You know, I think, Amir, one of the most interesting things about the drug-eluting balloon trials is how well the non-drug-eluting balloons have performed. I mean, the drug-eluting balloons have shown benefit, but if we just look at the standard balloon angioplasty arm of those trials, the results are far better than what people have historically published. Maybe that's technique related.
You know why, Greg?
Possibly also case selection and lesion length.
Yeah.
Do you know why? Because they were all short lesions.
I think you're right.
That's exactly what I'm trying to say. In SFA, short lesions do well with balloon. Balloon is not as bad as, you know, everyone led it to believe. And the reason that that was a very astute observation, Greg, by the way, and that you saw much improved balloon angioplasty result in this type of the work that is presented. And the reason is they were all short lesion. So not only drug-eluting balloon did well, regular balloon did better than other trial.
You know, and Amir, I think also your workup of this case told us a lot. To start with, we see dense calcium. But when we see dense calcium, everyone has been taught to believe that that's intimal. But it's not always intimal. In fact, usually it's medial. In this case, it was truly intimal, and you showed that very nicely with your intravascular ultrasound. That really does require something that can mechanically break the calcium. However, most calcium is not that way. Most calcium is actually in the media, and you can try with all the things that we have that doesn't necessarily work. What a beautiful result.
And I think also Dr. Vermani showed some very excellent data demonstrating that if someone has severe calcium and you use a drug balloon, very little drug makes it into the artery. You really have to do some form of decalcification before the drug can actually penetrate.
Amir, I think you're going to have a heck of a time making that look any better. That really looks impressive.
I think it's good. As I mentioned it before, considering everything, I think this is a good result, and definitely he's going to improve. And we see him on follow-up, see how well he does, and the less we do, the better it is. And so I think I'd like to look at the my distal protection with a push it a little bit down. Do one injection to see what we got into the basket.
Crucial point to make sure you're not spilling things when you go to recover the filter. It's a very crucial point. Looks okay.
There is some there, you can see that. Yeah, but not a lot. Oh, I've seen, yeah, and the reason is we didn't do atherectomy for a long segment. But there is something there, but yeah, I think you really, if you do atherectomy, you ought to put a distal protection device in. And I don't care what type of atherectomy it is, you got to get it. We do it with CSI, we do it with Foxhall. Even when I do an angiojet, I put a distal protection device. A lot of time, maybe you don't get anything, but for a few times that you get it, believe me, it saves you so much time and so much energy. Well, I think I did very well as far as the time concerned.
You did, and you did a great job in terms of the technique and the teaching. Amir, thank you much for a masterful, as always,
Oh, thank you.
outcome.
Thank you.
I'd like to invite the next panel to come on up for this next session. I am heading out to...